Sustained colonoscopy quality improvement using a simple intervention bundle. Introduction. Colonoscopy is the gold standard investigation of the lower gastrointestinal tract and is widely performed, with over 500,000 procedures performed annually in England and 15 million performed annually in the United States. High-quality colonoscopy is crucial to ensure adequate mucosal visualization and maximize detection of pathology. However, variation in quality of colonoscopy exists. The adenoma detection rate, ADR, is the most widely used colonoscopy quality indicator and is defined as the percentage of procedures where at least one adenoma is found in a patient. Colonoscopists with low ADRs have significantly higher rates of post-colonoscopy colorectal cancers and poorer outcomes in their patients. Approaches to improving ADRs have included enhanced optics, devices attached to the colonoscope tip, feedback, and leadership training. Several studies aiming to improve ADR through practice change have been undertaken. However, only one study has demonstrated significant ADR improvement, and this was among expert bowel cancer screening colonoscopists. These results have not yet been replicated in a non-expert colonoscopist cohort. Multimodal approaches have been adopted to incorporate a number of measures to improve colonoscopy quality. The Endoscopic Quality Improvement Program, EQIP, combined educational sessions with feedback and demonstrated ADR improvements. However, similar improvements were seen in control groups that received only passive monitoring. Introducing evidence-based medicine into clinical practice is challenging, with multiple potential barriers including lack of time for training, perceived lack of time to implement change, and uncertainty regarding the impact of change. Pronovost et al. Demonstrated that a bundle of interventions could be successfully implemented by combining training, feedback, and support to reduce catheter-related bloodstream infections in intensive care units. Using a similar approach, the Quality Improvement in Colonoscopy (QIC) study, previously published in Endoscopy, changed practice by introducing an evidence-based bundle of measures into routine colonoscopy practice. Colonoscopy quality, as measured by ADR, was improved. This study is unique in its approach to implementing a bundle of measures in endoscopy. QIC was a large, multi-center pragmatic study undertaken within the Northern Region Endoscopy Group, NREG, a well-organized endoscopy research network in the northeast of England. The study consisted of central and local training, in addition to anonymized contemporaneous performance feedback. The bundle included a number of evidence-based measures: minimal cecal withdrawal time 6 minutes or more, hyoscine butyl bromide use, supine patient position for examination of the transverse colon, rectal retroflexion. Hyoscine butyl bromide use, licensed in Europe as an antispasmodic, increased, as did ADR, the latter particularly among colonoscopists with low baseline ADRs, where ADR almost doubled in the lower quartile of performers. The author's hypothesis was that the effects of the pragmatic QIC intervention would lead to a sustained change in practice. Neilson et al. Aimed to evaluate ongoing uptake of the bundle in addition to colonoscopy quality 3 years following implementation, without delivery of any further interventions or training during the 3-year period. Methods. This observational study collected data from 8 hospital trusts sites in the United Kingdom for a 6-month period, 3 years following QIC bundle implementation. Use of the antispasmodic, hyoscine butyl bromide, was measured as a marker of bundle uptake. Bundle effectiveness was measured by ADR change. Comparisons were made between data before and immediately after implementation of the bundle. Results: 28,615 colonoscopies by 188 colonoscopists were studied. Hyoscine butyl bromide use increased from 15.8% pre-implementation to 47.4% in the sustainability phase, p less than 0.01, indicating sustained engagement with QIC measures. ADR was higher in the sustainability period compared with pre-intervention, but only reached statistical significance among the poorest performing colonoscopists. Conclusions. The introduction of a simple, inexpensive, pragmatic intervention significantly changed practice over a sustained period, improving colonoscopy quality as measured by ADR, particularly in poorer performers. QIC demonstrates that an easy-to-implement quality improvement approach can deliver a sustained change in practice for many years post-intervention.